So just to give an outline of this talk, we'll start first with some background on dementia and rural dementia care in particular, and we'll review two major RADAR initiatives. And RADAR refers to the Rural Dementia Action Research Team and Program. Then Belize will review the use of health administrative data to identify cohorts of persons with dementia, including those living rural. And Jacqueline will describe our recent studies. And finally, we'll spotlight Canadian teams that are conducting dementia-related research with health administrative data. Dementia is the loss of cognitive functioning and behavioral abilities to the extent that it interferes with daily life and activities. Dementia can be thought of as an umbrella term that includes many different brain diseases, with Alzheimer's disease being the most common. Symptoms of dementia are progressive. However, early diagnosis might point to a different condition, or if it is dementia, then early diagnosis can facilitate access to treatment and provide time to plan for the future. Some possible symptoms, as shown in this infographic from the Alzheimer's Society of Canada, include memory changes, loss of initiative, difficulty doing familiar tasks, and other possible changes. This figure shows the life course model of 14 potentially modifiable risk factors for dementia from a 2024 Lancet report. If all 14 risk factors were to be eliminated, this model proposes there would be a 45% reduction in cases of dementia globally. That is, 45% of cases could be prevented. In early life, in early life before age 18, the main risk factor is less education, suggesting the importance of good quality education being available for all. And in midlife and late life, evidence suggests specific actions to reduce dementia risk around the life course, such as treating depression, encouraging exercise, reducing social isolation, and other actions. And overall, the report emphasizes the importance of being active in midlife and late life in terms of cognitively active, socially and physically active. And the report suggests prevention to decrease risk factors should start in early life. The earlier, the better. And it's never too early or too late to reduce dementia risk. Also, the report suggests that all of the risk factors have the potential for risk reduction through policy changes. Globally, the estimated prevalence of dementia is 57 million, which includes diagnosed and undiagnosed. And the number of new cases each year is 10 million. In Canada, there are an estimated 771,000 prevalent cases, and the number of incident cases is estimated at 125,000. Here in Saskatchewan, where we are, there are an estimated 18,400 prevalent cases and 3,200 incident cases. I want to just mention two key reports from the Alzheimer's Society of Canada. And the first is Navigating the Path Forward for Dementia. And this report provides estimates and forecasts of rates. And the second report, The Many Faces of Dementia, focus on differences by sex and ethnicity. Turning to dementia diagnosis and management, one issue is that diagnosis is often made late, if it's made at all. And in terms of underdiagnosis, one review found that over 60% of cases are undetected. We do have a national dementia strategy in Canada. It was released in 2019. And the strategy recommends that timely diagnosis, which would facilitate earlier access to treatment, information services, and supports. And evidence shows that family physicians and nurse practitioners are essential to effective dementia care. And the College of Family Physicians of Canada advises that family physicians should be involved throughout the dementia journey, from counseling about prevention to end of life, with specialist referral in certain circumstances. So that would be rapidly progressing dementia, young onset, and atypical dementia. Studies have found that people with dementia, compared to without, require more care over time and require higher levels of care overall. In Canada in 2023, Alzheimer's disease was found to be the 9th leading cause of death. Studies have also found that people with dementia have a higher rate of acute care, hospitalization, increased length of hospital stay by up to 2 times, also higher rates of home care visits, higher rates of family physician visits, and higher rates of potentially inappropriate prescribing. So why do we focus on rural dementia care in particular? In Canada, about 16% of the population lives outside of cities of 10,000 or more and would be considered rural. This is nearly 6 million Canadians. About 20% of all older adults age 65 and over live in rural areas of Canada, and this is about 1.4 million older adults. Looking at Saskatchewan, about 1/3 of our population lives rural, and we have a very dispersed population and a lower population density compared to Canada overall. In Saskatchewan, 40% of all older adults live in rural areas, and this represents approximately 80,000 older adults. Given that rural communities have a significant share of older adults, they do need special consideration when it comes to certain medical conditions such as dementia. Also, the literature shows definite inequities in rural health services for people living with dementia. Rural areas of Canada are aging more quickly than urban centers. There are shortages of rural health professionals, and they have heavy workloads. In Saskatchewan, the number of nurse practitioners, registered nurses, and physicians has decreased in rural areas since 2017, which has led to concerns about staff burnout and lower retention. In rural areas, there's low access to specialized resources like health professionals with training and experience in dementia care, low access to supportive services like daycare and respite, and caregiver support groups. So, given the fewer specialized resources, people can face delays in receiving a formal diagnosis until the disease is more advanced, which can further reduce access to healthcare and support services. Also, some rural services may be inappropriate to disease stage or incompatible with needs, just because there are fewer services available in rural areas, and therefore services might be underused. And rural people might be reluctant to use services even if they do receive a diagnosis, or reluctant to disclose their diagnosis to others due to perceptions of lower privacy and confidentiality in rural areas. Now, I would like to mention two main initiatives by our RADAR team to improve rural dementia care. Our main initiatives focus on improving diagnosis and support for rural people living with dementia. We offer a specialist rural and remote memory clinic, which we'll mention again in a few minutes in relation to the health administrative data. And we've collaborated with rural primary healthcare teams to establish memory clinics in several sites in the southern part of the province. Also, since 2008, we've held an annual Rural Dementia Care Summit. It's now held virtually, which allows us to host the event for researchers and knowledge users from across Canada and internationally as well. And this event helps to raise awareness and share the latest research in rural dementia care. RADAR's one-day specialist rural remote memory clinic is funded by the Provincial Ministry of Health and has been running for over 20 years. The mandate of the specialist clinic is assessment, diagnosis, and management of atypical dementia for people living in rural and remote communities. The one-day clinic provides a full-day assessment by an interdisciplinary team. And although the mandate of the clinic is to diagnose atypical dementia, in years past, the clinic has received many referrals for more typical dementia, like Alzheimer's disease, for example. And this pointed to an opportunity to build capacity in primary healthcare, where Canadian guidelines recommend most diagnoses should take place. For this reason, we collaborated with local primary healthcare teams in rural communities to develop one-day rural primary care memory clinics. And this is our second main initiative. There are 10 sites currently. The main purpose of these local memory clinics is earlier diagnosis and management of people living with suspected dementia, to offer wraparound services and supports and establish relationships earlier in the process, and with the aim to avoid crises, which was an issue that we identified in an early needs assessment. We also have research underway to adapt, to adapt the primary care memory clinic model into different formats that involve virtual care. The first is a hybrid memory clinic model, where we're adapting and evaluating a model that involves virtual participation by an occupational therapist. The second is a home-based virtual memory clinic model, where a home-based, or rather a home care nurse, will travel to the patient's home, where they will conduct their assessment and other team members will participate virtually in the appointment. So turning now to how our RADAR team uses health administrative data. Several years ago, we began working with the Saskatchewan Health Quality Council with Jacqueline and Belize to learn about gaps in rural dementia care. And these early studies with administrative data really helped to inform our current initiatives, including the primary care memory clinics. We released a gap analysis report in 2015 that included a best practice review of national dementia plans, an environmental scan, and results from our very first analysis of health administrative data, where we identified prevalent and incident cases of dementia in Saskatchewan. As part of this work, we also examined time trends in incidence and prevalence from 2005 to 2013. And this was an interesting project because at the time there were few studies that had looked at both dementia incidence and prevalence in the same cohort. What we found was that the incident rate had decreased by 11%. And at the same time, we found the prevalence rate had increased by 31% in the same period. At that time, our explanation for decreasing incidence was possibly healthier behaviors and better prevention and treatment of vascular risks. And our explanation for increase in prevalence were possibly earlier diagnosis and longer survival time with dementia. And now I will turn it over to Belize to talk more about the health administrative data that we've used in our studies.
Thank you, Julie. Hi, everyone. So I'll take us through the data world a little bit, and probably I'm aware that many of you are aware with the administrative data, but it's worth mentioning that there are some important nuances and jurisdiction-specific differences. So our analysis work included health administrative data and clinical data, so I will try to share a little bit about them in the case of what these data include in Saskatchewan, how we identify dementia cases and why it matters when we are thinking about rural and remote communities. Then I'll hand it over to Jacqueline. So what you see on this slide represents the databases used in our analysis, which includes information from personal health information, such as demographic and public health coverage of the residents, administrative and clinical information from hospital discharges, emergency department visits, physician encounters, home care services, prescription drug records, and long-term care admissions. Some of these data sets, particularly hospital discharge abstract and emergency department records, follow established national standards and are broadly comparable across jurisdictions. However, other data sets may vary by province in how they are collected, coded, and covered. For example, in Saskatchewan, community pharmacy dispensing data capture prescriptions for all ages and populations, no restrictions. As we see from this list as well, administrative health data gives us a system-wide record of health services use. And what makes these data sets especially powerful is their breadth and opportunity for linkage. And as it relates to that linkage piece, I also included that other sources box in this slide. And this is to explain the information we get from post-code conversion file and the clinical data that we linked for some of our analysis, which I will get to in the later slides. In Saskatchewan, administrative health data sets are held by multiple trustees, and these are principally Ministry of Health, eHealth Saskatchewan, and Saskatchewan Health Authority. And Health Quality Council, the organization I work for, accesses and uses these data under established data sharing agreements for research and health system improvement. And I won't go into details about the data privacy, governance, or usage, but I wanted to include this because often the biggest hurdle when we are starting research or any improvement work is where the data lives and how to access it. So now we have our data. How do we identify dementia cases consistently? Next slide. To identify dementia cases in administrative health data, we applied the Canadian Chronic Disease Surveillance System case definition. The Public Health Agency of Canada established the CCDSS in 2009 to provide standardized national estimates of chronic disease prevalence, incidence, and outcomes across jurisdictions. Under the CCDSS definition, an individual is classified as having dementia if they meet any of the following criteria: a hospital discharge record that includes a dementia diagnosis, 3 or more physician claims for dementia occurring within a specified time frame and adequately spaced apart, or a prescription for dementia-related medication. This definition is grounded in the work of Yakiman and colleagues who developed and validated health administrative data algorithms for identifying Alzheimer's disease and related dementias using reference standard derived from family physicians' electronic medical records. Their algorithms demonstrated high specificity, around 99%, and good sensitivity, about 79%, supporting reliable identification of dementia cases in administrative datasets. This work is so valuable for population-level questions like, how big is the issue in Saskatchewan? How is it changing? And once the CCDSS algorithm is applied, we can go to the next slide. Administrative data have several important uses. As I mentioned before, it enables national surveillance because provinces and territories can run the same approach locally and share aggregate results. It supports population monitoring, helping us track dementia trends over time, and informs policy and planning, things like resource allocation and service design. And from a research perspective, it's also useful for studying patterns of service use, such as hospitalizations, length of stay, long-term care admissions, mortality, and where gaps might exist. One important caution is that equity-related variation by race, indigeneity, language, or geography has not always been well assessed in the validation work, so we need to interpret patterns thoughtfully and keep improving methods. So this was the administrative side. Next, I want to open up that other sources bucket, especially the clinical data. Clinical data we have used in our analysis is from that specialist rural and remote memory clinic. This dataset includes much richer clinical detail than administrative data alone for a smaller subset of individuals. The individuals are all Saskatchewan residents living more than 100 kilometers from 2 tertiary care centers in Saskatchewan and who need a comprehensive interdisciplinary assessment for suspected dementia. I will call this clinic data RRMC data going forward. RRMC data can include patient demographics and rural remote classification, referral pathways such as who referred the patient and how they entered the system, clinical assessments such as cognitive screening measures, and information about functional status. Importantly, clinical data can include diagnosis information, including dementia type and sometimes severity or stage, elements of care planning, such as follow-up recommendations, community supports, or medication initiation. This is the kind of detail that helps us move from how many people to what type of dementia, how it presents, and what supports are recommended. especially with a focus on patients living in rural and remote areas. Next slide, please. The specialist clinic is housed at the University of Saskatchewan, and it was built to reduce the burden of repeated long-distance travel. As Julie also mentioned, a key feature is the streamlined one-day interdisciplinary assessment, typically involving a neurologist, neuropsychology team, and other disciplines coordinated so that patients and families can get a comprehensive assessment in a single visit. This also means diagnoses captured here are clinically confirmed, and we often have a subtype detail, like the ones listed on the slide. This subtype detail is exactly what administrative data tend to miss. So RRMC data can help us understand diagnostic timelines, access barriers, and outcomes in rural and remote populations. So what happens when we put admin data and clinic data together? Next slide. If you ask me how many and where, that's administrative data, how it's shifting over time across the population. The trade-off is that we are missing the subtypes. If you ask what kind and what happens next, that's clinical data, but it's smaller and more resource intensive to collect. The clinic data with administrative data, linked with administrative data with the unique de-identified health service number, that linkage is the bridge to equitable dementia research and meaningful improvement in the health system. Next slide, please. So I know Julie already mentioned about the size of Saskatchewan, but I feel like this is something I'm still wrapping my mind around how vast this land is. And Saskatchewan has the population of 1.2 million with 652 square kilometers. So you could fit countries like France, Thailand, or Ukraine inside Saskatchewan with some room to spare. So population is quite spread out. For our scope, it is important to be able to define rural. For that, we rely on linking postal codes to census geography using Postal Code Conversion File Plus, which allows classification using Statistics Canada definition. Essentially, rural areas are those outside census metropolitan areas and agglomerations or communities under 10,000 population. It's also important to flag few limitations. Postal codes don't always reflect actual service access, boundary areas can be misclassified, and rurality measures vary across provinces, limiting comparability. Next slide, please. So when we bring all of this together, we are intentional about how we use it. In rural Saskatchewan, long travel distances, limited access to specialists, and delays in diagnosis are real barriers. And services that are available don't always align with person's stage of dementia or the needs of their family. Our approach is to study variation because inequities often overlap, and we look beyond rural and urban differences to examine patterns by age, sex, gender, income, rurality, and health complexity. Bringing these dimensions together is important to help us pinpoint where gaps in care exist and identify improvements that make a real difference for families and communities. So before we dive into findings, I want to take us over the limitations and some of the takeaways. So next slide, please. I have been sprinkling these throughout the presentation, but just to go over them once again, first limitation here outlined as the case definition does not always equal diagnosis state. We identify dementia based on earliest recorded ICD code or dementia-specific medication. But that administrative marker may occur well after symptom onset or even after the clinical diagnosis. So when we look at timelines, we are looking at recorded events, not necessarily clinical reality. The second, there's a risk of underestimation. Threshold-based definitions can work well for people with consistent access to care, but may undercount those who face barriers. So particularly in rural and remote settings, people might have fewer encounters captured in the system. Third is the administrative data often lacks detail on dementia type and severity. And why this matters is that we can rarely distinguish Alzheimer's versus other dementias or describe staging, which limits how precisely we can tailor interventions or interpret progression. And finally, data quality issues. Incomplete records, coding variation, and misclassification are always considerations with routinely collected data. However, these limitations don't make the data unusable. It's far from it. They just mean we interpret results with care and keep improving methods through linkage with clinical assessment and validation work. And with that context, I'll hand it over to Jacqueline to walk through some of these findings.
Thank you so much for that, Belize. I have been working with administrative data for about 20 years now. And when people who work outside of that ask me what I do for my job, I say I'm a data geek because it's just too complicated to say otherwise. And when they go, oh, that sounds interesting, my favorite saying is, the geek shall inherit the earth. And it really is true. Administrative data is incredibly powerful. And I will be sharing with you the results that have come out of our work using administrative data. I'll go through 3 publications, building on each of them. The first one, we created a cohort of people with dementia in Saskatchewan, just over 2,000 people. And I'll go through the methods which are applied to all 3, but I'll give you the detail here. Between April 1st of 2013 and March 31st, 1 year of 2014, we identified people who met the Canadian Chronic Disease definition of dementia. We then identified controls using the administrative data. These were people that we matched on the age, sex, comorbidity burden, urban versus rural location, and the geographic region that a person lived in Saskatchewan, like north versus south. We matched them to make them as comparable as possible. Then we looked back 5 years before that diagnosis date, and then we looked forward 5 years after that diagnosis date. We were specifically interested in physician visits, both family physician and specialist, hospitalizations, and drug dispensations. What we did for each of them was to compare within each year the occurrence of that health services use between the people with dementia and those without. The orange is people with dementia, the blue is people who are the controls, and you can see, if you can see my marker, right there, this is people who had at least 1 hospitalization within a year, and it's really pretty similar in the first 4 years, but in that year right before the date of diagnosis with dementia, there's a big difference. People with dementia were twice as likely to have that hospitalization. And the trend still continued for 2 years after. And the stars at the bottom indicate that that was a statistically significant difference in that year. And we did this over with physician visits and specialist visits and drug dispensations in each year. And now I'm going to try and show you the overall threads of what we did. It's an awful lot of analyses. It's an awful lot of data, which would only be possible by using the administrative data. In the first 5 years, or the 5 years before the date of diagnosis with dementia, every single person with the group with dementia had a statistically significantly lower number of physician visits to GPs and specialists, and also drug dispensations compared to people who did not have dementia. Hospitalizations were the same. When we looked at just physician visits for the rest of that time, people with dementia had a greater use, with specialists greater around the time of diagnosis, less after, and higher drug dispensations, even hospitalizations around that time. Where we noticed the biggest difference, like literally the biggest difference between the two, was in the year before diagnosis with specialist visits and hospitalizations. People with dementia had higher rates compared to non-dementia. And in family physician visits and drug dispensations, it was the year after that it was significantly increased. The point to take away from this is that people with dementia have distinctly different patterns of health services utilization, both before and after their diagnosis. Over the 10-year study period, people with dementia had increased family physician visits and drug dispensations. And in that year before and year after, it was very different for specialist visits and hospitalizations. We then wanted to further explore this cohort that we had created, looking at the rural-urban differences. So it was exactly the same 2,024 people with dementia, same methods, same outcomes, stratified by urban and rural. With the results, again, this is going to be just people with dementia, and the comparison variable is rural versus urban. We found that people in rural areas had fewer family physician visits than people in urban centers. Absolutely with specialists, fewer visits, fewer drug dispensations, no differences in hospitalizations. And again, that's among people with dementia living in urban and rural centers. We then did the same thing looking at people without dementia in rural and urban centers. We found a similar pattern, not for the drug dispensations, but for family physician visits and certainly for specialist visits, people in rural areas access those services less. The message to take away from this is that people living in rural areas have fewer physician visits regardless of dementia status. It's something very, very different. So now we want to put the peanut butter and the chocolate together, as Belize has indicated, with the admin data and with the clinical data to really fill in those gaps. This cohort is just of 436 people with dementia, no controls. We linked the data, looked 5 years after, 5 years before, and this is what we found. Among people with dementia, over time, the physician visits increased, drug dispensations increased, dementia-specific drug dispensations increased closer to that time of diagnosis. Consistent with the other research, the previous that we'd done, the specialist visits had a different pattern. It decreased after diagnosis, as did hospitalizations. To sum up those three pieces of research, and there's a whole lot more detail that we could go into, but just the big ones to take away with you for now is that there are indeed differences in that use of health services between people with dementia and without, and it is greatest in the year before and the year after they were diagnosed. People living in rural areas they use family physicians and specialists less often than people living in urban. And it's there for people who don't have dementia. It's even more there for people who do have dementia. And within the specialist memory clinic, patients had a gradual increase over time in family physician visits. So I'm now going to turn it back to Julie for her to bring a close to this presentation, and then we can open it up for questions.
Thanks, Jacqueline. So overall, we want to highlight that rural-urban inequities in dementia care exist, and that rural older adults face greater barriers across the entire dementia care pathway. They tend to have less access to family physicians and specialists and less access to dementia-specific community supports. And taken together, these challenges may contribute to delayed diagnosis and unmet care needs for rural older adults. And rural memory clinics, both the specialist clinics that we mentioned and the primary care memory clinics, these are one of the strategies that we have supported as a way to address these gaps. And before we end, I just want to mention two new Canadian teams that are using health administrative data for dementia research. The teams were recently funded by CIHR as part of the Canadian Consortium on Neurodegeneration and Aging, which is a national network focused on dementia research and prevention, treatment, and quality of life. The first team is the Canadian Dementia Health System Performance Team, led by Susan Brunskill and Dallas Seitz. And this team will create a national platform. The team will measure the current quality of dementia care and report on care over time and identify gaps in health system performance. And the second team is focused on advancing equity in dementia care in Canada. And they're using health administrative data to highlight the interactions of gender, income, race, and language on healthcare use. And they aim to identify ways to reduce health inequities. And finally, I'd just like to acknowledge support for our research from several organizations and funding bodies.